So that's up for discussion, and really it's an evolution. But I think if you, again, want to practice like way in advance, right? You want to really be, proactive with this patient, I think there'd be very little harm. Or you wait, you scope them in 6 months, just like you may do with a post-op patient. You may choose to do nothing. Patient says, forget it. I need to detoxify. You've had me on all these poisons. I need at least 6 months to kind of get all this out, and then rescope me in 6 months. I may not be symptomatic, but look in. If I start to have ulcers, then you, just like a Crohn's patient, and then you start to prophylax them. Would you ever give a biologic to a patient who has ulcers, asymptomatic, just like a Crohn, like a Rutgers 2 at the, but looking at a different anastomotic area? Maybe. This is all for, discussion. Okay, so let's end with kind of therapeutic outcomes and just focus on where the second phase of the next decade is going, which is individualized pharmacogenetics, pharmacogenomics, and starting to think about stratifying patients into which therapy they should get. So I'm going to just focus on serologies. We have the paper was published in IBD Journal, or it's on EPUB and IBD Journal, where we ran the entire genome against Remicade responsiveness and found 4 genes that were actually associated strongly with responsiveness. But I'm going to just focus on serologies, because that's commercially available and/or available. It's a concept. We've had serologies for a long time. Running a whole genome, and where are you going to buy this, and who's going to, what commercial lab is going to run the entire genome for you for $10 is not happening right now. So let's focus on serologies, which we get for other reasons. And so this dates back to 01. In 01, it actually was thought and suggested, based on original data, that p-ANCA was a predictor of non-response to anti-TNF therapy in Crohn's patients. What this was, if you could believe it, these are the original 1997 New England Journal patients from the 1 dose of Remicade. 2/3 response, 1/3 non-response at 12 weeks. Remember that? Those days when we gave 1 dose of Remicade? That was, 13 years ago. And now these are the patients, and we wanted to know, why was there disparate in those patients as to who responded and who didn't? And my mentor, Steph Targan, really is the one who's pushed through all of these immune reactivity markers and said, immunologically, which is how immunologically they must be different, right? So he went back and he ran serologies on the entire cohort from the study, and actually what it ended up being is that the patients who accounted for the response in the original Crohn's study were ASCA positive, p-ANCA negative. And those patients who did not mount a very strong response were p-ANCA positive and ASCA negative. So remember what I said. p-ANCA is on one end, ASCA is on another. What I can also tell you is ASCA loves anti-TNF therapy. It's a TNF. There's something associated with pure ASCA and TNF. p-ANCA, not so much, isn't a player with TNF. And that's why in your UC patients who are p-ANCA positive, you may get an initial response, because anyone with inflammation has TNF hanging around, right? There's no doubt that you have TNF even when you go to Mexico and get sick, right? TNF is a player in inflammation. But the reality is, what's the real player in a p-ANCA positive patient? What is that immune reactivity that we need to be suppressing? It's probably not anti-TNF. So the reality is, what we often see is patients get better after the first 2 infusions. By the time they're coming for their week 6, or maybe you can get them out to week 10, they're back to exactly where they were before you started the biologic. And I would guess p-ANCA is a major player in that. And what we told Abbott when they were running their Abbott trial for UC, which wasn't very successful, they said, why do you think people didn't respond? I said, did you do serologies? I mean, you need to start to stratify, whether genetics, I don't care if you do stool, some kind of stratification, so you could have gotten your drug to work 85% of the time, for example, in people who are p-ANCA negative, ASCA positive, right? Or actually, that means they had Crohn's, so take that away. But in the right that would be hilarious. But in the right diagnosed patient, seronegative, for example, or low p-ANCA. So this was a study from Europe that confirmed that in early responses, is patients who come out of the gates and at basically 10 weeks looking at early induction, and another study that showed if you're p-ANCA positive, ASCA negative, it's a 50-50 chance of you responding in the short term. Long term, we don't know. That wasn't a maintenance component. If you're seronegative, 7 out of 10 patients had a response to the induction. And if you're ASCA positive, you have Crohn's, so you have 100% response rate. This was in their UC patients, so this was the European cohort. So again, hinting to the fact immunologically, p-ANCA is a unique subtype, ASCA is a different subtype, therefore we should stratify patients based on their underlying immune phenotype. So this is the paper that's in EPUB in IBD, and this is showing you our data, showing you that 76% of patients who did not respond to induction of infliximab were p-ANCA positive versus only a third of patients who responded. So again, hinting to the idea that immunologically there's a difference between this patient and that patient, and maybe you should start to individualize your treatment based on their underlying immune response and stop trying to classify them as UC and Crohn's and saying, oh, we can use this in everybody, but to start thinking one level deeper, literally what's going on at the mucosa, and start to target those patients. So the last notion, which is just to show you the treatment impact on the natural history, this is myself and Corey Siegel, and it was actually just accepted yesterday to IBD Journal, is to develop, our goal was to develop and validate a graphically displayed patient communication tool. So Akbar, you can appreciate our goals of doing this. And it really was to visualize risk to patients, right? To have this as a discussion risk tool, and Dartmouth this is what they do. They're very much into decision tools for patients. And so what this is, those 796 patients where I showed you the surgical curves and I showed you the 6-fold increased stricture and 9.5 increased risk penetrating, these are them. So what we have is on a computer program, you can actually alter the toggles. So you can say that this patient was a 16-year-old female who had both small bowel and perianal disease, and she was positive for all the serologies. Okay, so this is obviously, you know where I'm getting to because I showed you all the predictors. The only thing I needed to add was had very deep ulcers at diagnosis. You can appreciate what the natural history of this patient is. So based on what we know, the hazard ratio, et cetera, was calculated based on this model. And if this patient walked in your room and the patient said to you, what's my probability of going to surgery because of a complication, based on our modeling, you could see that out to 2 years or even less, a year and a half, 100% of patients would end up with a complication if you met this criteria, right? This is important. Now, a 6-year-old boy with colon only, complication rates about 25% over a long period of time. So again, and who has very low quartiles, right? Very low serologies. So it's about starting to differentiate your patient into risk so that when I sit in front of a male patient who's 6 and I'm telling the mom, you know, we really need to go on biologics, maybe I need to rethink it. Maybe that isn't necessarily what we need to go on to, because maybe I'm not going to change the natural history of the disease. And I actually have that slide in a 6-year-old, but I think I only have it for, here. This is a 16-year-old female. This is true treatment data. This is what we actually did, meaning in the patients that we had, he actually took all of our treatment decisions, and we were blinded to it. We actually sent it to him, each of our different sites, and then they actually put in treatment option 1 is within 90 days, treatment option 2 is after 90 days. So in those patients who got biologics within 90 days, and these are the patients who had perianal, small bowel, and 16-year-old, this is what their natural history looked like. So that's a much better way of communicating to patients that you can actually alter the natural history. And you believe it, we believe it, we think we can actually slow down. Didn't you show we can slow down fibrosis? Yet? Your grant will? Your R01? Okay. So you will show that we can actually, hopefully, right, slow it down and alter. And it's all based on early intervention. I mean, that's what I think even more so the discussion with our families and our patients is please use it early, right, if you're going to use it. And when we go out and give talks to community physicians, our message is please don't wait 5 years, right? This is what our message is. Use it early before you get too far gone in the process. And this was a way to communicate. I mean, it looks like an absolute reduction of 75%, right? Maybe it is, I don't know. We're currently validating it prospectively in our PEDS population to try and see, and we're also going to do it in an adult population to see if this is true. So, and this is what I love. This is the last point, which we all need to recognize, is when we use steroids in our patients,